session will be from Professor Dawlat Belal, Professor and the Head of the Nephrology Department at Cairo University. And presentation will be about delayed graft function and early graft loss.
Good morning. I'd like to thank Professor Fuad for inviting me to this talk, and I hope it is quick and effective. Mr. Chairman, the Chairman, and audience, the first few slides in this lecture are not related to the lecture. There are some statistics to show how important the graft is, and how rich, how expensive it is, and why we should try to keep it as long as possible. This lecture will hit the following points: transplant statistics, definition of delayed graft function, incidence, causes, impact on patient and graft survival, relation to acute rejection, relation to chronic allograft nephropathy, prevention and treatment. In this study carried by Fresenius Medical Care, it shows the following. The world population is 7 billion. End-stage renal disease patients are 3 million treated for end-stage renal disease. On hemodialysis, 2.2 million, nearly 2 million. On peritoneal dialysis, 252,000. On transplantation, 652,000. The annual growth rate for the world population is 1.1% per year. End-stage renal disease patients grow by 7% every year. Hemodialysis patients by 7 to 8%, PD by 8%, transplantation by 4 to 5%. So we see that the growth rate of the end-stage renal disease patients is far faster than the world population. And if we break down the renal replacement therapy, the transplant population are the least to grow, which makes sense now. This bar graph is going to show the renal replacement therapy along the years, from 2000 to 2012. The blue part is the renal replacement therapy by hemodialysis and peritoneal dialysis, and the gray part is by transplantation. And you see that the ratio between the transplantation and the dialysis is the same all through. Transplantation is not growing. There's a consistent increase in the renal replacement therapy numbers. 2000, they were 1.5 million. 2005, they were 1.8 million. 2010, 2.5 million. 2012, they are 3 million. So consistently, 3/4 are being treated by dialysis and the rest by transplantation. Some view of some transplant statistics. According to the UNOS, United Nations Organ Sharing System, and the OPTN, Organ Procurement Transplant Network, which are concerned by locating the grafts and locating the recipients. So as of June 2013, last year, 16,812 were transplanted, out of which 11,000 were living and were deceased, and 5,700 were living donors. I'm going to show you this. This is a breakdown of the living donation because it looks funny to me compared to what we have here. What we have here, these are the statistics of the United States. The only people who make statistics in Egypt are the Mansoura people, and the rest are all يعني اجتهادات. Okay? So I found the following, which it's very interesting when you compare it to our situation. The age of the donors, 42% are between 35 and 48. unlike ours. Ours are younger generations. 38.4 are males and 61% are females. Also, this is different from ours. Our donors, living donors, are always male, mostly males. The ethnicity, this is theirs. African Americans are 11%, the whites are 70%, Hispanics are 13.6%, the Asians are 3.5%. The Asians are peculiar, they are very closed community people. They give each other. They will not give anyone outside the Asians. Parent to child is 880. This is, I saw this in Abu Rish with Professor Patino when I go in the ethical committee. The donation from the parents is so high, especially from the mother. Child to parents, this I found very strange, is 508 cases, which is a lot. Identical twins, 12. Full siblings, 1,133. Yani brothers and sisters there are very generous. Half sibling, 61. Other relatives, 437. We don't see this here. Unrelated, 165. In Egypt, there are almost 95% are unrelated. Waiting list of transplantation in the US. As of June 2013, 118,617 are waiting for transplantation of all organs. 96,000 are waiting for a kidney transplant. 3,000 are added to the list each month. So every 10 minutes a patient is added to this list. 13 patients die daily while waiting. Last year, 4,903 patients died while waiting. كل الكلام ده بقوله ليه؟ عشان يوري قد ايه الجرافت حاجة precious and I should do all my effort to keep it alive. Now we go to the topic of this lecture, definition of delayed graft function. When I reviewed the literature, لقيت فيه 18 definition. I don't know why. لكن the three most common definitions are those. It is acute kidney injury related to the process of transplant itself. وفي بعض الأقوال it is ATN related to the transplantation, not even acute kidney injury, ATN related to transplantation. The second one is the use of dialysis within the 7 days of transplantation, which is not really correct because there could be delayed graft function short of using dialysis. I just wait and wait and wait until it picks up. The last one is the most feasible, is failure of serum creatinine to drop by 10% on 3 consecutive days in the first week of transplantation. ودي كلها KDIGO guidelines. And it's important to unify the definition علشان أقدر أعمل compare studies all over the centers. What is the incidence of delayed graft function in the US? From 1985 to 1992, delayed graft function was 14.7%. From 1998 to 2004, it jumped up to 23%. 2008 upwards, delayed graft function was 21%. طبعا it looks funny, but it isn't funny when you know that this is caused by expansion. It goes hand in hand with the use of expanded donor criteria donors. I take any kidney which comes with all the defects, and the donation after cardiac death. These two factors make the drop or the increase in the delayed graft function. And we really can't blame people for using expanded criteria donors because they need the grafts, and people die waiting for grafts. Causes of delayed graft function are causes related to the donor and causes related to the recipient. Causes related to the donor, the first event is brain death. Brain death itself is a predisposing factor to delayed graft function. And then, of course, ischemic injury after harvesting and putting into ice. And then the inflammatory signal sent by the harvested kidney to the immune system of the recipient. Recipient causes are, after we declamp the artery, the reperfusion injury itself. Ischemia causes injury and reperfusion causes injury. Innate immune response by the recipient, adaptive immune response by the recipient, perioperative period, which is very important, and perioperative fluid status. Maybe you all know people who are involved in transplantation. Sometimes the patient comes upstairs to the nephrologist bloated, bloated يعني pre-transplant weight مثلا was 50, post-transplant he's 65. This means that the people downstairs are very nervous and they want to inflate the patient very much, and they want to perfuse the graft as much as they can. And they never even, sometimes it's very disturbing, you find the patient bloated and you don't get even in the operative notes how many liters he was taken. But if you know how important it is to perfuse this organ, you would really say, okay, it's okay. And if there's prompt action of the graft, or work of the graft, it will get rid of this fluid over the next days. The state of brain death before harvesting the organ. The brain death situation is not a peaceful, quiet situation. It's usually a very hectic situation in the ICU, and the patient doesn't stay for a long time. Usually there are road traffic accidents, there are brain injuries, all sorts of injuries all over the body, and in this situation it is a state of inflammation. What happens in the brain stem death here is that the brain, the pituitary and hypothalamus starts to send signal everywhere all over the body. To the suprarenal to produce corticosteroids, to the lymph nodes to stimulate the lymphocytes to produce all sorts of cytokines. This produces a generalized state of inflammation leading to vasoconstriction in the graft, in the brain dead person, before harvesting the graft. And if you go to watch the brain dead person in the ICU, you know there's a brain dead person downstairs, so you go on every day to see what's happening. It's not every day, it's usually a quick process. You find that the ICU people are giving plenty of fluids, plenty of oxygen, blood transfusion to boost up the hemoglobin, and this is to maintain good perfusion of this kidney, because the whole body is in a state of hypoperfusion and hypoxia, which is deleterious to the graft when you transplant it. So in the pre-procurement period, before harvesting the graft, why is it important to maintain a potential brain dead donor on high perfusion pressure, ample oxygenation, ample hemoglobin? This is what the ICU people do this. Now the duration of the brain death and the duration of the stay in the ICU has an effect on the occurrence of delayed graft function. If the duration of brain death exceeds 24 hours, ICU stay exceeds 40 days, this predisposes to delayed graft function. Brain death alone is a state of inflammation producing free oxygen radicals. The kidney during the brain death is in a state of vasoconstriction. In Leiden University, there are many trials to vasodilate the blood vessels in the kidney before harvesting. So they infused dopamine into the brain dead people to produce, to cause vasodilatation, and they found that the delayed graft function was reduced from 35.4% to 24.7%. All trials are made to take care of the brain dead person, and the infusion fluids into the graft after harvesting the graft to prevent the vasoconstriction. Donation after cardiac death is a worse situation, because we have a long lapse time between the cardiac death, the cardiac arrest, and the harvesting of the organ. So straightforward, this organ probably has ATN. Usually it has ATN. Speaking of the ischemia injury, I'm speaking about the donor causes now. This diagram shows ischemia reperfusion. We are considering this part of the diagram which is concerned with the donor. There is pathologic vasoconstriction here. There is severe vasoconstriction due to injury of the endothelial cells producing endothelin, and this of course is going to affect the tubules and leading to endothelin, excess endothelin, and ATN. This is the ischemia part of the story. Usually the graft has this picture, which is ATN, which is either patchy or diffuse, and the severity depends upon the cold ischemia time and the extent of vasoconstriction in the donor. What happens after reperfusion? Reperfusion is not the end of the story, it's the beginning of another backstory. So reperfusion, what happens is that nitrous oxide is produced in huge amounts to try to counteract the effect of the endothelin by the perfused kidney after declamping. But excessive amounts of nitrous oxide can lead to vasoconstriction alone in itself. The second step that happens after the recipient perceives that he has a foreign body, which starts in 6 hours, is activation of the lymphocytes to stimulate the immune system. So endothelial recruitment of T lymphocytes, this is the graft. After declamping, the cells are going to recruit the lymphocytes, and the lymphocytes are going to be activated and activate the immune system to start the process of rejection, which starts in 6 hours. Reperfusion causes upregulation of the major histocompatibility antigens expression. And it's not only a cytokine problem, no, it's also an immunological problem. Here, if interferon gamma causes upregulation of the major histocompatibility antigen receptors causing acute rejection. Thank you. So the reperfusion injury, if it's not covered, if the patient is not covered by ample enough immunosuppression, we can go into a sort of acute rejection, which could be as much as vascular rejection, hyperacute, what we call hyperacute rejection. Is there an immune component for delayed graft function? Yes, there is an immune component of the delayed graft function, and we all know that we all experience this 5th day rejection. Actually, it's not the 5th day, it occurs on the 3rd day, but we see that the creatinine starts to rise at the 5th day, and some people give routinely a bolus of extra steroids on the 5th day. It should be on the 3rd day. Why the 3rd day? Because it's a period of stopping the heavy immunosuppression as the steroid boluses and building up the immunosuppression due to CNIs and mycophenolate. So the sort of a gap there that could be exposed, it could expose the patient to rejection. So does HLA mismatch have a role? Yes, it has a role for delayed graft function if I'm not covered with proper or ample immunosuppression. Panel-reactive antibodies, when they're over 50, of course, we get rejection and causes delayed graft function. Presensitization of the patient's second transplant with transfusions, cross-match and donor-specific antibodies, all these add up in acute rejection. So the result is that acute rejection and delayed graft function interact with each other. Delayed graft function gives a milieu which is very inviting for acute rejection. Acute rejection, when it is added to delayed graft function due to other causes, is very deleterious on the long-term survival of this graft. So what is the extent of accepting expanded criteria? This is very different from one center to another, and it's very different according to the availability of the organs. But Irish اللي هو ادانا بعد كده نوموجرام ازاي نحدد دي هيحصل delayed graft function ولا لا, said that if the age of the donor is above 75, this decreases, of course, the functional nephron mass of the kidney. And he has comorbid conditions like diabetes and hypertension. If I get the situation in kidney graft, perform a pre-donation biopsy and refrain if sclerosed glomeruli exceed 20%. This is not a generalized rule, and we don't know who does what in his center. Now, donor factors continued. Other composite donor factors are putting a female graft into a male recipient due to hormonal imbalance. In the female, she has female hormones which are vasodilatory, which are not present in the male recipient. Donor age and donor weight. Small for size kidneys, example of the anencephalic fetus, we take the 2 kidneys en bloc and put them in an adult. We should use a small size adult, although they grow by time. They grow in size. Recipient causes are, the composite recipient risk factors for delayed graft function are maintenance dialysis prior to transplantation. It was found that the longer the period of dialysis before transplantation, the more incidence of delayed graft function. Obesity. Delayed graft function in morbid obesity or high obesity can occur in 57.5%. Diabetes, it can occur in 36.3%. If the age of the recipient is over 55, female into male recipients, African Americans, long waiting list which is related to the dialysis time, immune sensitization by pregnancies and transfusions and previous transplants, perioperative course, course, and the mean arterial pressure less than 100, which is very deleterious to the graft. As I told you, the main aim in the first few hours of the first 2 days is to secure very good perfusion of the graft by infusing plasma extenders and fluids and maybe blood transfusion. Now, how to predict the occurrence of delayed graft function? This is important to allocate the recipient, not the donor. And what happens in cadaveric graft is that you have a patient with 2 kidneys, a brain dead patient, and you have hundreds of potential recipients. How are you going to choose the recipient which is the least to develop the delayed graft function? Many nomograms have been invented. The most sensible one is one made by Irish. In this nomogram you will see the following. Each point, each item...
Dear doctor, your time is up.
Is it? خلصت الساعة؟
ممكن ناخد دقيقتين.
ناخد دقيقتين ناخد
ممكن ناخد دقيقتين كمان.
دي حته مهمه دي.
دقيقتين كفايه كده؟ فاضل حاجه دقيقتين.
هختصر بسرعة يعني. طيب. النوموجرام ده هينقي لي الريسيبيانت مش هينقي الدونر. فبشوف الايج والاتش هي ماتشنج وكل واحدة من دول هتاخد نقط. الديوريشن اوف dialysis is it the first transplant or the second transplant. وهنا تحت هيجيلي الار ار. يعني اللي هي relative incidence يعني هيحصل قد ايه delayed graft function. طبعا اقلهم ار هو اللي هياخد الجرافت. ليه يعني الامباكت اوف delayed graft function على السرفايفل اوف الجرافت في الناحيه دي من التيبل اللي هو الحاجات اللي بتاثر على السرفايفل in the first 6 months. هنا الحاجات اللي بتاثر على السرفايفل بعد 6 months. هنلاقي ان delayed graft function بتشتغل هنا وبتشتغل هنا. Does the delayed graft function have an impact on the long and short time survival or not? The short time, yes. On the long time survival مهم جدا إذا حصل معها acute reaction ووجدوا إن الكرياتينين level at the end of the first year is very important for the long time survival. Delayed graft function and acute rejection هما they interact. هو predisposed to acute rejection و acute rejection plus delayed graft function reduces very much the chance of the graft to survive. وإن الأكيوت ريجكشن إبيسود نفسها بتقلل الهاف لايف اوف ذا جرافت from 6 to 12.5 years لوحدها. delayed graft function أكان لقينا إنها الار مع delayed graft function إن كان يحصل 6.1 أكتر من diabetes اللي هي 5.8 وأكتر من hypertension اللي هي 3.1. impact on long term survival برضه studies في تشاينا نقوا إن لما بيحصل إن في الجرافس اللي عاشت أكتر من 10 سنين الديليد جرافت فانكشن فيها كانت أقل. الجرافس اللي عاشت أقل من 10 سنين الديليد جرافت فانكشن فيها كانت عالية. ده التريتمنت is mainly is to avoid إزاي إن أنا properly allocate the recipient. Management of established cases في algorithm بسيط جدا. أنا دلوقتي عندي delayed graft function I should exclude pre-renal and post-renal causes and surgical causes.
Your time is up.
Okay. The second thing to do معلش السلايد دي بس ونخلص. لقيت ان I excluded these factors I should biopsy to rule out acute rejection. هو دي أهم حاجة rule out acute rejection. Hemodialysis only when indicated. Don't overuse of hemodialysis عشان ال ATM بتتأخر لما تستعمل hemodialysis كتير. Maintain hemodynamic stability. CNI avoidance أو replacement is controversial. في ناس بتبطلها وتنقل ATG covered by ATG. في ناس بتنقل sirolimus و everolimus. It's controversial. في ناس بس بتقلل CNI. ATG ممكن coupling with ATG will reduce acute rejection فهيقلل long time of long effect of the خلاص. That's it.
Thank you very much, Professor Belal, for this elegant presentation.
One question?
One question.
We are short of time. One question. No question.
Our session is closed and invite speakers and second.
عاملين الناس الوحيدين اللي عاملين
عامل ازعاج ليه؟ طول عمر بقيت زهل.
امريكا. طب انا رايح روسيا بقى. طب انا رايح روسيا.
اللي راح روسيا.
انا رايح روسيا بقى.
احنا بنروح روسيا.
والله رايح روسيا والله.